Dr. Beuers, at APASL 2020 today, during your talk, you mentioned an association with China. You said that when you would speak there 20 years ago, the Chinese would say they have no PBC, and now that's changed. Can you discuss that?
I think it's always a problem when you make a diagnosis of a new disease. It's a problem of awareness that you also look for the disease. And I was impressed by this development when I was the first time there speaking, and I've been meanwhile 12 times in China, giving 1 to 7 talks, 1 to 8 talks at one stay. And this issue, cholestatic liver diseases, where I talked today about diagnosis and management, has in the beginning not had a lot of interest because people said we have a lot of hepatitis B, but we don't see these autoimmune, immune-mediated diseases. And we know from colleagues from Shanghai who did excellent investigations on that the rates of, let's take the example of PBC, primary biliary cholangitis, as we name it now, since 5 years, that the prevalence rates are very similar to European prevalence rates, 30, 35 in 100,000 inhabitants. So this comes down to 1 in 1,000 women with 50 years of age. And that becomes relevant, and in particular relevant because we have now good treatment for this disease. As a typical example of a cholestatic liver disease, the most frequent chronic cholestatic liver disease, and with also 2/3 live a normal life with normal life expectancy. Formerly, they died after a mean of 10 years from liver failure and the consequences when they didn't get a liver transplantation. And probably it can be comparable to other cholestatic diseases like primary sclerosing cholangitis, which in former years also was said it does not exist in that frequency as it exists in the Western world. But I think we have to look also there more carefully and also to see whether we don't overlook it. And with PSC, we have learned a lot in the last 10 years, and we learned a lot that not everything what we call a patient with PSC, not everybody has this PSC. The best example now is the IGG4 related cholangitis. 15 years ago nobody knew that this exists, and now we know that 10-15% of our patients whom we called PSC have IgG4 related disease and are completely differently treated and successfully treated with corticosteroids. PSC does not react on corticosteroids. So we just have to be better in our awareness for the diseases to make the diagnosis, I think. For PSC, we still think that this is a very difficult disease. I talked about the pathogenesis in PBC. We know today, that was the first I mentioned now, primary biliary cholangitis, we know today it's probably not an autoimmune disease, what we thought the last 20 years. It's probably, this is my view, but I share this view with more and more colleagues. I think it's a secretory disease, secretory defect in the production of bicarbonate in the biliary tree. And we know now that bicarbonate is a key protective factor in the bile ducts, and when bicarbonate is not enough produced by the biliary epithelial cells, then the patients get problems with their bile ducts because the bile acids in the bile ducts are very aggressive. And when you don't have the protective, what we call biliary bicarbonate umbrella, then the cholangiocytes, so the cells surrounding the bile ducts, are not protected enough. And we think today that this is a key in understanding these diseases, and all the immune mechanisms are probably secondary to the damage of the bile duct epithelial cells by bile acids. And this is also experimentally shown already. So we have enough data on that to show that first, the secretory defect for bicarbonate, second, immune reactions in those persons who tend to develop this kind of disease. So there are genetic factors which make the difference. One individual will develop this disease, the other one will not develop this disease. We know in PSC, as opposed to PBC, in primary sclerosing cholangitis, has a high risk of developing cholangiocarcinoma. Up to 13-15% of the patients will develop during the course of their disease, and these patients are young usually, cholangiocarcinoma. So we do annual ultrasound to look also at the gallbladder. the gallbladder. In 3% of 2 large cohorts, they found gallbladder carcinoma. So we do annual check of the gallbladder and the bile ducts and the liver with ultrasound. Maybe in the future, when we will be able to afford that, but I think it's much too expensive, we will even do annual MRI and MRCP. But at this moment, I think annual ultrasound is fine. We also do, you can discuss CA99 determinations annually, but the data are not that convincing to do that, because also inflammation induces increases in CA99 as a biochemical marker. The second annual test we always do is colonoscopy in patients who have the combination of PSC with inflammatory bowel disease, which 2/3 of the patients have with PSC, and these get annual colonoscopy to look for dysplasia in colon carcinoma, because colon carcinoma frequency is 5 times higher in patients with PSC and IBD in comparison to patients with IBD alone. So high risk for development of carcinoma.
You also covered the Igg-4 disease, and you talked about the high sort criteria.
Yes.
Could you please define that for us?
Yes. The Igg-4 related disease, we know today this is a problem. On my own outpatient clinic, I have about 100 patients with this Igg-4 related disease who all were wrongly diagnosed, and 1/3 of them underwent hemihepatectomy or a Whipple procedure for a Whipple's operation for suspicion of cholangiocarcinoma or pancreatic carcinoma, and finally there was only inflammation, which could have been treated with corticosteroids successfully. This is 1/3 of the patients, and 2/3, they are misclassified as PSC, for example, primary sclerosing cholangitis, because they have the same signs, only they react very good on prednisolone, what PSC doesn't do. So this Igg-4 related disease, we know today that 10-15% of our PSC cohorts are not PSC but Igg-4 related disease, and we will in the future detect other diseases which mimic PSC but are not PSC.
So what is that high sort criteria?
That's the diagnostic criteria we use in the Western world to make a diagnosis of Igg-4 related disease. And high sort means H histology with plasma cells, Igg-4 positive plasma cells with a storiform fibrosis in a phlebitis, obliterative phlebitis. These are the 3 criteria. 2 of them you have to fulfill in the histology workup of your tissue. And I is imaging, and that is swelling of organs, like typically autoimmune pancreatitis type 1, which is one organ manifestation of Igg-4 related disease. S for serum marker, and that's serum Igg-4, but serum Igg-4 is only elevated in about 70-75% of the patients, so this is a non-sensitive marker, unfortunately. O is other organ involvement, and that can be the pancreas, the bile ducts, it can be the prostate, it can be the testis, it can be, which we first described, it can be the lungs, it can be lymph nodes, it can be glands, thyroid can also be, and salivary, the salivary glands are one of the most frequent. And as you see, these are all secretory organs, glands. And I think the pathophysiology is linked to mainly glands. And we have an idea about that, but this is too early to talk about that. And RT, high sort, is the response to treatment, to corticosteroid treatment. They are responding very well.
So during that Igg-4 talk, you gave 2 interesting illustrations. One was having to do with a beekeeper, and the other one was, you said that occupational allergens play a role. Can you talk about that?
First, the beekeepers. So that's a nice story, because our research started with that on Igg-4 related disease. My fellows and mine, it was 1 fellow and myself, and now the 3rd fellow is working on that, PhD fellow is working on that. We have fascinating results. But it started all with our idea that beekeepers, there's an old paper from 1997 where beekeepers from the Canarian Islands were investigated on Igg-4 in their blood, and they found that beekeepers who longer keeps his bees, who more immunoglobulin G4 he develops. And what was also obvious was that those beekeepers with the highest levels of IgG4 were best protected against severe allergic reactions. So we think, based also on this observation, but in meanwhile also our own data and data of others, that IgG4 is an immune system damping immunoglobulin, and it's not the aggressive immunoglobulin. It's one which turns down a little bit a too heavy reaction of the immune system when it meets its antigen. So it's a protective mechanism, we think. And that was our idea from the beekeepers, to look for clones, IgG4 clones, B-cell receptor clones, using a next generation sequencing technique, fancy technique, new developed. And we saw that our IgG4 patients had dominant IgG4 clones, whereas healthy persons, the first IgG4 clone in comparison to IgG1, IgG2, IgG3 clones is number 100. But these IgG4 patients have in number 1, most of them, their first IgG4 clone. And this was strikingly different from other patients and healthy controls, like patients with elevated serum IgG4, PSC patients, cholangiocarcinoma patients. They had their IgG4 clone in number 100 or so. And so we had a 100% sensitivity, 100% specificity using this very, very complicated and time-consuming and costly technique. But we could, with 100% sensitivity and specificity, make a difference between IgG4-related disease and PSC and cholangiocarcinoma, which are the major differential diagnoses when you have a patient with IgG4-related cholangitis.
So the moral of that story is, go get yourself stung by bees to be healthy?
That's a good question, but
or is it eating honey?
I fear I eat a lot of honey, but maybe it's the reason why I'm protected against IgG4-related disease.
Great.
But the answer is unfortunately no in this case, because the IgG4 against the sting, against the bee toxin, is not the IgG4 we need for the IgG4-related disease. So to protect our organs. So we need to eat something else.
So the other question was, you said a lot of blue-collar workers are showing up with this disease.
This was our observation, that in our cohort in the beginning we saw a certain type. It's known now that most of the patients are male, 85% about, and most are elderly, above 60. And we were puzzled by that. And my fellow went to the first 25 patients to their home and took a very careful history and so forth. And we found out that a large proportion of our patients was blue-collar workers. It was far above 80%, and still now it's 75 or so. With what we have at this moment, about 100 patients I see on our patient clinic. They were truck drivers and tent truck drivers and ship captains and painters and other professions where you use a lotot of solvents, diesel, oil products. And
toxins.
Environmental toxins, yeah. At work, mostly at work, during work, exposed to these.
So they're having an allergic reaction?
It's probably not an allergic reaction as we see allergic reactions. It's another kind of. I think the first step is taking up these substances, whereby we are still busy identifying the molecules which are the culprits for initiating this disease. But I think many of them inhale them, and then they get to sensitive organs, and the pancreas appears to be a center which is sensitive to this, because most of the patients have autoimmune pancreatitis and then other organ involvement, and this can be a silent autoimmune pancreatitis. Then autoantigens are formed or are detected by the immune system and possibly attacked, and then the disease goes its way. And this apparently, because the exposition is for a long time, or it can also be a long time ago, over years. This seems to be a very slow process, but more I can't say at this moment.
In your summary, you said a real key is to take history again and again
Yeah.
and again. Can you
This is-
explain that?
Yeah, this is I showed a case in the beginning with a jaundice patient and worked up extensively in another hospital, and they didn't find a diagnosis. And what I did, how I found the diagnosis, was not fancy, expensive investigations that had all been done, but asking the patient again and again and again what could be the cause of her disease. And finally I found out that she had been treated with an antibiotic 4 weeks ago, and she had forgotten it, and her daughter also had forgotten it, but it was documented on a piece of paper which we could get by WhatsApp from the other daughter, and she also had forgotten it. So it was a drug-induced liver injury, as we have that very, very often, and we overlook it very, very often.
So you had the suspicion and you just kept
Yeah, but
going at it.
this is I do that since 30 years, so
Lucky for her.
yes, she was the most happy person.
So last question is, there seems to be a large cooperation between EASL and APASL.
Yes.
Can you talk about that friendship?
Yeah, we this is a long-term relationship, and we also try to always to have interactions, and also to do joint actions in developing guidelines in mainly these things, joint strategies in the diagnosis treatment of diseases. We have in part different patient groups, but in many cases the same problems, certainly. And we can only learn from each other, and finding together the best way to effective diagnosis and treatment of our patients. I think that's the secret. You have to collaborate, and it's only for everybody the best to do.
Schön. Herr Doktor, vielen Dank.
Graag gedaan.